Okay, so started with a case per usual. So a 74-year-old woman is seen for preoperative medical evaluation before a section of the sigmoid colon 3 days from now. She has a history of non-valvular AFib and is receiving apixaban without a history of bleeding complications. She has no history of stroke, TIA, or intracardiac thrombus. History is significant for hypertension. Her meds are apixaban, chlorothalidone, and metoprolol. So the question is, what is the most appropriate perioperative management of this patient's anticoagulation? A is continue apixaban, B is stop apixaban, start aspirin, C is stop apixaban, start enoxaparin, and D is stop apixaban altogether. So maybe take like 5 seconds, think about what you would choose, and then we will kind of move on. Alrighty, so the goal of this talk, I would argue that the correct answer to this patient is to just stop the apixaban altogether. So just a very brief background so we're all on the same page. So for AFib, there's clear benefit to anticoagulation for prevention of stroke in patients with elevated CHADS-VASc scores. For most procedures, ideally, anticoagulation is held somewhere between 12 hours and 5 days. And shout out to a previous Fast Facts Friday, you can calculate the daily risk of stroke by some somewhat complicated math if you're interested in doing that. And then the big question here is, how do we balance the risk of perioperative thromboembolism and the risk of perioperative major bleeding? So luckily, we have some evidence to answer this question, which I will go over briefly here. So this question was basically approached in the BRIDGE trial, which is a 2015 study in New England Journal of Medicine. Essentially, the study compared holding anticoagulation versus bridging anticoagulation with low molecular weight heparin for patients with known AFib undergoing elective procedures. So just briefly on the study design, basically the patients who were undergoing elective procedures, they were randomly selected to one group or the other. All these patients were on warfarin, so they held warfarin for 5 days prior to the procedure. And if they were chosen to be bridged, they would get low molecular weight heparin for 3 days prior to the procedure. And then it was started immediately after the procedure for another 5 to 10 days. And then the primary outcomes were thromboembolism, which was a combination of stroke and TIA, and then major bleeding. And this is a patient selection. Just to point out, they were very similar between the two groups. The one important thing to note here is that the average, this study also used the CHADS-2 score instead of the CHADS-VASc score, but on average, the vast majority of patients were CHADS-2 scores like 1 through 4, and there were very few that were 5 or 6. And so in terms of jumping to the results here, so basically the rates of thromboembolism did not significantly differ between the two groups, and there was actually a significantly higher rate of major bleeding in the group of patients receiving bridging anticoagulation, which is shown on the table on the right here. And so from these results, the conclusion from this study was that holding anticoagulation for patients with lower CHADS-2 scores is safe prior to procedures, or the risk of arterial thromboembolism is unchanged. And so this we can kind of apply to practice. So in terms of the most recent guidelines, so the 2019 AHA, ACC, HRS guidelines, on the left here in the red box, the actual guidelines for atrial fibrillation, it's a little bit vague, and it mentions that you should balance the risks of stroke and bleeding and the duration of time a patient will not be anticoagulated. But then they also include this portion right here that basically directly references the BRIDGE trial, and the last sentence here mentioning that bridging anticoagulation may be appropriate only in patients with a very high thromboembolic risk. So the guidelines seem to generally reflect this statement, while also taking into account your own clinical judgment. And so then in summary, for bridging anticoagulation for atrial fibrillation, in patients with non-valvular AFib and a CHADS-2 score of less than or equal to 4, the evidence suggests that holding anticoagulation in the perioperative setting does not increase the risk of arterial thromboembolism. And then in patients with a higher CHADS score, the evidence is less clear and should really warrant a longer discussion of kind of the risks and benefits based on that patient and the surgery that they're undergoing. And then on the right here in this box, it's really important to take into account that this doesn't apply to other patients. So in patients with valvular AFib, like severe mitral disease, that hasn't been well studied. And then in patients with other indications for anticoagulation, such as like PE DVT, this also doesn't apply. And so this is kind of a good way to think about your patients, whether they're inpatient or outpatient on anticoagulation for AFib. So yeah, any questions?
That was really nice. I do have a question. So we're always calculating CHADS-VASc in our patients. Should we just be calculating the CHADS and then using this and ignoring the VASc part?
I think it's a good question. I think if you're directly interpreting the literature, then I guess technically you should be, but the CHADS VASC, if anything, errs on the side of like more points rather than less points. So if your CHADS 2 VASC is also 4, then it essentially fits with this criteria as well. But I think if you have a CHADS 2 VASC 5 or 6, it's a little bit gray because it's not clear whether you would have added 2 on CHADS 2 or not, is my own interpretation.
Yeah, that's what I do too.
There's a question in the chat from Neil.
It's a good question. I will say the question is whether there's data on whether bridging with low molecular weight heparin or unfractionated heparin. I actually don't know. This particular study obviously used low molecular weight heparin, but I'm actually not sure if there's any direct data on that. I don't know if anyone else knows. Yeah. So, sorry. Cool. All righty, guys. Thanks for joining.